the second free paper session. May I invite the moderators for this session, Dr. Saxena Alexander, Dr. Jigar Shrimali, and Dr. Pravash Chaudhary. Please note, specific timings have been allotted for each of the sessions. You have a total of 10 minutes, 7 minutes for the talk, and 3 minutes for discussion. Kindly request the speakers to stick to the timings and humbly requesting the moderators and chairpersons to ensure the same. This is for the smooth conduct of the program, requesting your cooperation for the same. May I invite the moderators once again, Dr. Saxena Alexander, Dr. Jigar Shrimali, and Dr. Pravash Chaudhary. Let's move to the first talk of this session. Dr. Saxena Alexander, Dr. Jigar Shrimali, and Dr. Pravash Chaudhary.
So good afternoon, everybody. It's a pleasure to me to participate in this Congress. I would talk briefly about the International Registry in Organ Donation and Transplantation, which is named ISOT, to compare the data from 2019 versus 2020 worldwide. I would like to introduce this registry for those of you that don't know it yet. This ISOT is a free open data source registry in organ donation and transplantation. And it's the registry. It's been created in 1998. And since then, out of 111 countries with the donation and transplantation activity have submitted data to our platform. Our goal is to provide a global overview in donation and transplantation. As you can see here, this is the website. And here you have an example of the different charts that we are showing beyond the newsletters that we are updating every year. The methodology of this ISOT platform consists in the following steps. First, each participant country inserts their own data to the website, and all data is validated. Then the information is according to the definition of the critical pathway of disease donation, ensuring uniformity throughout the registry and helping with the correct interpretation of the data. Then the data is verified by our team that usually contact the official reported when needed, and then the compilation of all this information can be assessed by the whole community. In case that any report specialized or different studies has been proposed to us, specific investigations could be provided by our team. We presented the numbers from 2019, and as far as we know, 80 countries submitted the registry, the data to the registry. And in 2020, as you all know, the donation and transplantation rates dropped due to the emergency of the COVID worldwide. But we have able to collect at least 65 countries data from 65 countries so far. So in the EU, the most affected countries were Spain, Croatia, France, Belgium, and Italy. And in South America and the Middle East, countries also reported a downward trend in disease donation numbers. But it is quite interesting to know that in the case of US, Slovenia, Estonia, Denmark, they were able to report an increase numbers in the disease donation activity. Regarding the living donation, as you all know, the living donation programs were mostly deferred in 2020, but so far 54 countries have submitted data in 2020, and the decrease in the living donation activity were between 18 and 67% compared to the previous year, except for Israel, Ireland, Estonia, and then Slovenia. So regarding the donation after circulatory death programs, 12 countries reported activity in 2020, with Spain, the US, UK, Australia, and Austria at the top. So getting deeper into these results, I wanted to show you this graphic that, summarized the donation, disease donation activity. And well, as I was mentioned before, here you have highlighted the countries that were able to not only maintain, but to increase the activity, and comparing to the last years, and even in the middle of the pandemic. And well, the first is the US, but then we have cases like Austria, Slovenia, Estonia, Denmark, South Korea, Latvia, and Hong Kong. So getting deeper into the Asia numbers, when we compare almost 20 countries in the Asia continent, well, we were surprising when we found that, the activity in most of the countries dropped, but in the case of Hong Kong, Thailand, and Malaysia, the numbers were increased in mostly all of the categories that the registry allows. So here you have the kidney transplant from deceased donors numbers, specifically in Asia. And again, South Korea is highlighted because usually is at the top of the list, then followed by Israel, Iran, and then we have Thailand and Malaysia highlighted because they were able to increase the donation rate. Passing by to kidney transplant from living donors in Asia. At the top, we have Israel, followed by South Korea, Turkey, which is common in these cases, Saudi, and then again, the Southeast Asia countries like Malaysia and Thailand were able to maintain the donation rates in this specific regard. Getting deeper into the actual living organ donors in Asia, I would like to here say that Israel, Malaysia, and Thailand were increasing, but countries like South Korea and also Japan and even Kuwait and also the UAE were able at least to maintain almost the same rates even in the middle of the pandemic. So in conclusion, in 2020, the challenge hospital faced, including restrictions, flight reductions, and border closures, affected the national programs worldwide, as reflected above. Nevertheless, the coordination and transplantive teams have minimized the impacts, and while the resources were affected globally, certain countries managed to increase the donation and transplantation rates. And with this, I finish my presentation, and thank you very much to all of you.
Thank you, Maria, for this report, global report. I will start the question and then I'll hand it over to the other colleagues here who are chairpersons. You have shown us a variation in the uptake of diseased donor as well as living donor transplantation between countries, with some having an increase and some having a decrease. What do you think are the reasons behind it?
I cannot hear you well. I don't know if you can speak a little bit loud, because I really don't.
Am I audible at all?
Yeah, it's better now.
Okay. So you have shown
you were asking about the reasons behind which fact?
Variation in the reports, variation in the registry. So variation among the country. Madam want to ask that, Dr. Suchi.
Yeah, I believe.
Increase of different countries. So what could be the reasons behind it?
Well, the first reason would be the impact, no, of the pandemic in the different countries in which well, they were able to manage in different ways. It's not the same case in Spain, in Italy, or India than in probably in Sweden or in Denmark. So the numbers were really different. Then here, for example, we were able to manage, but during a few months we had to stop, no, the programs, including not only the living but the disease and of course the DCD, no. So I believe that depending on the program that was previously set, no, in each country, and then depending on the numbers of the pandemic and well, the experience, because after a while some countries were able to start managing, no, the donation and transplantation programs, even with the pandemic, in different centers and with different criteria.
Dr. Pravesh?
Yeah, good afternoon. I think it was a good presentation. I just want to know, you have seen that in comparison to live-related transplant in various countries, even the donor program is also going on finely. Is there any thing is that which country is going more with DCD and what is the future prospect? Can you able to guess or throw some light regarding this?
You mean the future DCD programs?
Yeah.
Implementation?
Yeah.
Well, I believe it depends, no? It depends with the legislation first, and then the practice, no, among our own colleagues, no, the healthcare professionals that have to be clear about the protocols, no, the end of life care protocols, and in that regard, we have to to set a way to start, no, about thinking about these kind of DCD programs implementation. We have to be able to follow the pathway, no, of end of life care, and to set all the the criteria. And in our case in Spain, more than 30% of the donors are coming from that way, but because we are pretty aware of this pathway. So I mean,
okay, thank you.
So we will need to close this presentation.
Thank you.
Okay.
Thank you.
Thank you, Dr. Marian. Let's move on with the next free paper presentation. May I invite Dr. Susri Shashmita Das for the talk on short-term outcome of ABO-incompatible renal transplant recipients in COVID-19 era. Dr. Susri Shashmita Das.
Good afternoon, everyone. Myself, Dr. Susri Shashmita Das from Rabindranath Tagore International Institute, Kolkata. So I'll be presenting on my paper, short-term outcome of ABO-incompatible renal transplant recipients in COVID-19 era. So the primary objective of my paper is, though there have been multiple studies on the outcome of ABO-incompatible renal transplantations in our country, however, there have still been no study presenting the short-term outcome of ABO-incompatible transplants done in the COVID-19 era. So hereby we, in our hospital, in our center, we have analyzed 25 consecutive ABO-incompatible kidney transplant recipients from October 2020 till June 2021, who have been followed up till July 2021. So there has been a variable period of follow-up for a period of 9 months for patients undergoing transplant in October, and for a period of 1 month for patients undergoing transplant in the month of July 2021. So regarding the method, the desensitization protocol we have in our institute, we have included all the patients who are ABO-incompatible and they have received rituximab 100 milligram or 200 milligram depending on the baseline anti-A or anti-B titer. So in patients who have a B-transplant anti-A or B titer of more than equal to 512, we have given them 200 milligram per person, per recipient. And in patients who had anti-A or B titer of less than equal to 1:256, there we have used rituximab 100 milligram for the patient 14 days prior to transplantation. So then the patients were admitted for 7 days prior to transplant and undergone plasma exchange at 30 ml per kg, and the replacement fluid chosen was FFP of the donor blood group. The plasma exchanges were followed by 5 gram IVIG administration post plasma exchange. We also have one patient who had a baseline titer of 8 and he has received only rituximab 100 milligram and did not get either plasma exchange or IVIG administration. And another patient with baseline titer of 32, 1:32, where we have given one plasma exchange and 5 grams of IVIG and have transplanted the patient. The target pre-transplant anti-AB titer was less than equal to 1:64, and the patients received induction therapy with anti-thymocyte globulin at a dose of 3 milligram per kg in 2 divided doses on POD0 and POD1, and IV methylprednisolone 500 milligram on POD-1 and POD0. Coming to the results, the median duration of follow-up of our patients was 156 days. The highest baseline titer transplanted was 2048, who was transplanted with a titer, pre-transplant titer of 64 and is doing well with a creatinine of 1.25. The highest pre-transplant titer was 64, as already said. The mean serum creatinine at discharge was 1.36 plus minus 0.37, and at follow-up was 1.5 plus minus 0.75. The patient survival was 96%. And the death censored graft survival was 96%. The single patient who died also had graft nephrectomy and was due to fungal pyelonephritis, and the patient succumbed to fungal sepsis and multi-organ dysfunction. Among the transplant patients, 3 patients experienced episodes of biopsy-proven rejection, out of which 2 patients had active antibody-mediated rejection, who was given sessions of plasma exchange followed by IVIG and recovered well and were discharged. And 1 patient had T-cell mediated rejection, who was treated with IV methylprednisolone and was discharged. The average post-transplant hospital stay was 13 plus minus 4.5 days, and 4 patients post-transplant needed hospitalization, rehospitalization for infection, out of which 3 patients had GI sepsis, had the GI infection with stool panel array positive, resulting in dehydration, tacrolimus toxicity. However, they were managed successfully and were discharged with a good renal function. And 1 patient had culture positive UTI, who was managed with broad spectrum IV antibiotic and was discharged. There were no cases of pneumonia, cytomegalovirus infection, or BK virus nephropathy during the follow-up. Among the 25 patients, ABO-incompatible transplant recipients, 5 out of them were COVID-19 recovered, who were transplanted after a mean duration of 71.2 days, where they had mild and even moderate severity of COVID-19 during their pre-transplant period. 3 patients out of these 25 transplant patients acquired COVID-19 post-transplant, 2 of them in the early post-transplant period, that is within the 3 months of transplant, and 1 patient at 5 months post-transplant. All of them were asymptomatic with minimal symptoms and were discharged and were treated on home basis with medications. So coming to the conclusion, there were no significant differences in the patient and graft survival in COVID-19 era as compared to our pre-COVID studies. We also have another study during 2014 with 30 patients, where also the patient and graft survival was 96%. So we did not notice any significant difference if the transplantation was done with desensitization in the COVID era. Interestingly, the incidence of infection has gone down in view of the COVID-related precautions which are being taken in the transplant unit. We have a dedicated staff and dedicated doctors for the transplant unit who don't do duty anywhere else other than the transplant. And there was also no increase in mortality or infection in a shorter term of our study period. So we can conclude that it is prudent to transplant the eligible patients, considering the infection and death rate in dialysis is high for our CKD patients. Thank you.
Thank you, Dr. Srishri. Dr. Parvesh, do you want to ask one question and then go over to the next presentation?
Yeah, only one thing. All the 25 patients received ATG, only induction you have given, or something on the basis You have given simulate also. It's only ETG to every patient you have given.
Among these 25 patients, actually, according to the risk stratification of the patient, we do give basiliximab. But among these patients, ABO incompatible, we have given only rabbit ATG. But in other patients, even in COVID recovered, we did give basiliximab also. But in these ABO incompatible, we have given rabbit ATG only.
Okay, thank you. Thank you, Dr. Sushri. I think Dr. Suchina, if there is nothing, we can proceed for third presentation.
Is there anyone there?
Yes. Yeah. Thank you, Dr. Susri. Let's move to the next pre-paper on relationship between demographic and the cause of brain death during 5 years. Dr. Zanas Dehgani.
Name of God, my name is Dr. Sanas Dehgani. I'm working on sino organ donation, sino organ procurement unit, and behalf of my colleague, I'm going to start my presentation by title Relationship between Demographic and the Cause of Brain Death during 5 years in Sina Hospital. As an introduction, the shortage of organs has been a global problem and a worldwide health challenge. It is essential to improve the recovery of organs to meet the growing demand worldwide. At 2019, Iran reached a rate of 40.3 donors per million of the population, or PMP. Despite this, 7 till 10 of patients on the waiting list die every day in Iran. The aim of this study was examining the demographic characteristics of families who consent to donation, so that identifying the factors involved in this decision on encourage other groups and families to donate. This was a descriptive, analytical, cross-sectional study and performed on brain death cases in Sina organ procurement unit. Sina is one of the most important organ procurement unit in Tehran and Iran. All of the brain death cases that were identifying during 5 period year in the affiliated hospital of Sina Opus was as a participation. Brain death cases that are inappropriate for donation were excluded, and we continue by 297 brain death cases that had at least one suitable organs for transplantation and the families consent to donation. All of the donor families were surveyed by using a researcher-made checklist, including age, cause of brain death, education, occupational place of residence, marital status, number of children, and history of addiction. As you know, according to previous studies, common case of brain death in the world divided in several sections. One of the most of them is head injury and CVH, ISBD, or ischemic brain damage, tumor, hanging and drowning. And in our study, we almost 50% of the brain death cases due to trauma, and followed by CVA, suicide, hypoxia, toxicity, and other. Brain death knowledge depends on educational level and previous experience of brain death in their family or friends, family, talking with family, values, religions, beliefs, and other things. Demographic characteristics of brain death causes during 5 years in Sina OPU showed that the mean age of the participant was 35.3, and most of them are male, and most of them was married, and they almost 50% of them are had a lower than diploma level of education, and most of them have had self-employed. And the result of relationship between demographical features and cause of brain death showed that there was a significant relationship between age and cause of brain death. People who had a lower age, higher rate of the brain death causes, and male and people with lower than diploma and people with self-employed have a significant relationship with the cause of brain death. As a conclusion, we have to say more than of donors had not an academic education, and it means that education and knowledge toward organ donation may help to prevention from brain death. In addition, most causes of brain death in Iran are trauma due to traffic accident. It is very important to include organ donation issue in driving training classes to increase the knowledge about organ donation for participation. The author would like to thank all participants in this study, and we thanks for all your attention.
Thank you. Let's move to the next free paper, Dr. Maria Paula Gomez. Let's move to the next free paper, Dr. Maria.
Hi, good afternoon again, and thank you to the organizer for inviting me today. So I will share my screen, and we will talk about our experience in the Caribbean region. This paper is called Organ Donation and Transplant in the English-Speaking Caribbean Region, 10 Years of International Cooperation. So in this region of the Anglo-Saxon Caribbean region, there are about 1,200 persons reported to be suffering end-stage renal disease. And the main age reported is between the 50 to 16 years old. In contrast with this data, in 2006, only 21 kidney transplant patients were reported, one from Bahamas, one from Barbados, one from British Virgin Islands, and 18 from Jamaica. To get an idea, we are talking a region with 18 millions of inhabitants, near to 20 million of inhabitants, with a GDP of about 15,000 USD dollar. And in average, their countries are in the high human development index category. So we start the collaboration, Donation and Transplantation Institute, together with Trinidad and Tobago Ministry of Health in January of 2010, with the aims to develop their disease donation program for transplantation. It was thanks to the World Health Organization, the Pan American Health Organization. Of course, the beneficiary organization was National Organ Donor Program in Trinidad and Tobago, and the sponsor of this initiative was a Repsol Foundation. Also, in 2020, during the pandemic time, we start a collaboration with the University Hospital of the West Indies and the Ministry of Health and Wellness of Jamaica. And it was thanks to the partnership with Barcelona Clinic Hospital, and this initiative was found by TAIEX, which is a grant program from the European Commission. So the methodology implemented was the collaboration applies the CEUSA program, which is a compendium of standardized tools that combine best practice in organ donation, disease organ donation from three main models, Spain, Europe, and United States. So the idea is not to copy any of these models, is to get the best practice and then adapt and implement in a new territory. And it has 6 phases. The first one is about diagnosis study to evaluate the organ donation and transplant system. The phase 2 is about the human resources, the structure, especially to creating a transplant procurement managers. Phase 3 is about the implementation of a reporting system, which looked for alert 100% of possible and potential donors that we call disease alert system. Phase 4 is about to improve the conversion rate. Phase 5 is about awareness and training of healthcare professionals. So this is in order to create the culture of organ donation inside of the hospitals, and then we apply the essential in organ donation. And finally, the phase 6 is about quality program. So we audit the hospital with our international and including, of course, the national expert. So this SEUSA program have been applied in the 3 main hospitals in Trinidad and Tobago for the last 10 years, and the phase 1 started in Jamaica in 2020. The results after 10 years of collaboration, Trinidad and Tobago accounts with a transplant procurement managers network, which they are intensive care doctors, part-time dedicators dedicated to disease organ donation, and they are located inside of each of the main public hospitals. Have been possible to procure 126 organs and transplanted in Trinidad and Tobago from both living and deceased. And you can see here in this picture that from all Anglo-Saxon countries in the Caribbean region, Trinidad and Tobago is the only country who have been having a disease donor activity in this. What have been the learning opportunities for Trinidad and Tobago during these 10 years? The government support. So it's mandatory to count with the government support, means the politicians or the different health authorities, in order to all of these initiatives be transformed in policies and procedures. And then the hospital directive commitment. It's important that in each of these hospitals that have been implemented the program, the directors of the hospitals, medical directors, and all the governors of the hospital be committed to continue the program and to dedicate resources for this activity. So here in the figure, as I mentioned to you, 126 organs have been transplanted and procured, but you can see that there were years where there was possible to get at 7 donors per million of population rate, and unfortunately, as happened everywhere, COVID affect the disease organ donation activity, and then the last rate was near to 1 donor per million of population. We still, we are there, and we are also accompanying them in order to go back to the previous activity. Regarding Jamaica, as I mentioned to you, we start in January 2020, and we initiate with the diagnosis phase. So we were able to analyze Jamaica regarding the human resources, the infrastructure, the legislation, the training and financing in organ donation, and compare with the best practice recommendation, and do a gap analysis in each of these areas. We define a roadmap for the National Disease Organ Donation Program, and here in the figure that we can see is how, while Jamaica has a good human resources for disease organ donation and transplant, following but not too bad infrastructure, legislation and financing are the 2 main challenges that Jamaica has to face in the following year in order to succeed with the implementation of a disease organ donation program. As a conclusion, international collaboration has demonstrated effectiveness for the establishment of organ donation for transplant program, and the success of SEUSA is that of adapting the methodology to the needs of each country. Something to remark is that all these 2 programs, they have been sponsored by international organizations. So none of those 2 countries, non-Trinidad and Tobago, non-Jamaica, they have not been dedicated their own resources to sponsor these programs. No? And then during 10 years, many people have been passing to this and collaborating and supporting this program. So I have to thank Dr. Pepe Huitron, who is a neurologist surgeon, transplant surgeon, who accompany us. Also Dr. Anton Fernandez, who is a donor coordinator from one of our hospitals in Spain. Of course, Dr. Bernadette from the Pan American Health Organization, who play a key role in order to start this initiative. Dr. Entela Condi, that also is working with us in Donation and Transplantation Institute and was the coordinator of the project from some years. Dr. Leslie Villarroel, a former national transplant responsible in Trinidad and Tobago, and our TPMs, Dr. Hasina, Dr. Brigitte, and Dr. Priska, intensive care doctors who are dedicated, part-time dedicated to this, Dr. Vicento Regrosa, who is a nephrologist from Hospital Clinic, and Arancha, who is a nurse, donor coordinator, also involved at that time in our institute. So thank you very much, and I will be more than happy to answer any question.
Thank you, Dr. Maria. Lucid and clear presentation. It's very encouraging to see the results that you have achieved in Trinidad. I will start with one question and I'll give it over to the other chairperson. So, are there any government incentives that are provided to the families of the deceased donors to encourage donation?
Yeah, no, there is not any incentive. Trinidad and Tobago has an opt-in legislation, which means that all families has to be approached to consent organ donation. We are talking about disease organ donation mainly. So it's volunteer action, and there is not any kind of remuneration or support, for example, with funeral support or health insurance. There is nothing about that in Trinidad and Tobago so far.
Thank you, Dr. Pravesh. Over to you.
I think it's a nice presentation, and it's a it will be promote all the cadaver and every transplant here also. I think no more question from my side. That's good.
Thank you, Pravesh. Do we have any presenters?
Thank you, Dr. Maria. Thank you, Dr. Maria. Moderators, please note that was the last free paper session in this session. The rest of the speakers are unavailable. I take this opportunity to thank the speakers and the moderators for the session. With that, we have come to the end of the second free paper session.